One of the extremely important topics at present is the discourse on dementia. Dementia is often discussed casually and perhaps excessively, so I consider it appropriate to provide some explanations about this term, which may be used incorrectly. Dementia is essentially a progressive cognitive decline caused by various pathologies. Unfortunately, it has recently been asserted that one of these forms would be Alzheimer's disease, but in reality, there are several dozen pathologies that lead to dementia. Therefore, it is appropriate to delve deeper into this significant aspect.
Dementia is a progressive cognitive deterioration caused by a variety of pathologies, which will be listed below. First, it should be emphasized that the word dementia is a generic term that encompasses a set of symptoms without referring to a specific pathology. Among the various forms of dementia, which will be subsequently listed, Alzheimer's disease has become particularly widespread. It is a specific pathology with precise biological characteristics and, importantly, not a morbus, a term that indicates a disease with a fatal course of unknown causes. Even in common language, the term Alzheimer's disease or dementia, or simply Alzheimer's, refers to a person who presents a memory deficit significant enough to affect their daily life activities. Unfortunately, age-related cognitive decline, perhaps limited to a recent memory disorder, a very common condition beyond a certain age, is currently classified inexorably and inappropriately as Alzheimer's disease. It would be better to refer to it as cognitive decline. It is indeed necessary to emphasize that there is a significant difference between cognitive decline and Alzheimer's disease. It is important to remember, as mentioned above, that Alzheimer's disease is a disease with precise anatomopathological characteristics. To make a diagnosis of Alzheimer's disease, it is necessary to identify the presence of beta-amyloid plaques and tau tangles in the brain of the affected person through specific biomarkers. Consequently, it makes no sense to immediately classify as Alzheimer's disease a cognitive deterioration that may have other causes. Unfortunately, making a diagnosis of Alzheimer's disease in the presence of cognitive decline with involvement of recent memory is very common. Regrettably, this attitude is often present even among doctors. In fact, it is generally the family members themselves who diagnose Alzheimer's disease. The physician, sometimes even a specialist, often confirms the diagnosis of Alzheimer's disease. At this point, it is necessary to remember that Alzheimer's disease is a genuine disease not related to brain aging and has distinctive characteristics. Prion have been identified in Alzheimer's disease. In prion diseases, a normal cell surface protein in the brain called the prion protein is misfolded into a pathogenic form defined as a prion. The prion then causes misfolding of other prion proteins, resulting in a significant increase in abnormal proteins, leading to brain damage. In Alzheimer's disease, it is thought that beta-amyloid in cerebral amyloid deposits and tau in neurofibrillary tangles have self-replicating properties similar to prion. Symptomatology of Alzheimer's disease. The most common initial manifestation is short-term memory loss. For example, asking repetitive questions, frequently misplacing objects, or forgetting appointments. Other cognitive deficits tend to involve multiple functions, including the following. 1. Difficulty in managing complex activities and poor judgment. For example, being unable to recognize the value of money, making inadequate financial decisions. 2. Language anomalies, for example, difficulty finding appropriate words, pronunciation, and/or writing errors. 3. Visuospatial anomalies, for example, inability to recognize familiar faces or common objects. Patients with Alzheimer's disease are often better cared for and characterized compared to patients with other dementias. Initial evaluation in subjects with suspected dementia. Conduct a thorough anamnesis of the person to be evaluated, possibly with the help of a family member or someone who knows the patient well, both to understand the period of onset and the characteristics of the symptomatology, particularly memory and any behavioral disturbances. In any case, perform a general and neurological objective examination. request blood tests and cognitive tests, including the mini-mental state examination or more complex neuropsychological tests. Also evaluate the negative effects of anxiolytic drugs or major tranquilizers and possibly identify any reversible causes, such as depression of mood. If Alzheimer's disease is suspected, consider examinations such as FDG PET, fluorodeoxyglucose positron emission tomography, or perfusion SPECT, single photon emission computed tomography. Examination of cerebrospinal fluid to search for tau protein or beta amyloid 1 to 42 or 1 to 40s. It is also important to provide assistance to healthcare personnel or family members themselves, who may be under considerable stress. Nurses and social workers can instruct caregivers on how to meet patients' needs. Professional figures or family members themselves must identify any early symptoms of stress and psychophysical exhaustion of the person assisting the patient, and if necessary, indicate support services. Prognosis: in the early stages of dementia, before the patient becomes totally incapable, it is necessary to clarify the patient's wishes about the type of care they want to undergo and the management of legal aspects, for example, testamentary dispositions, provisions relating to medical care. When these documents are signed, the patient's decision-making capacity must be evaluated, and the results of the evaluation must be recorded. It would be advisable to make decisions in advance, before the need arises, about the use of artificial feeding and treatment of acute illnesses. In advanced dementia, palliative measures might be more suitable than highly aggressive interventions or hospital care.